Hi, everyone. Welcome to Saath, the S4 podcast, where we talk about substance use disorders within the context of the Punjabi community.
Through inviting mental health experts, researchers, community members, and those with lived experiences, we discuss everything from the history of addiction to the lived realities of Punjabi families, alongside providing relevant resources.
We are your hosts. I'm Ravia. I'm a community organizer and a researcher from Edmonton.
I'm Bavenjit Kaur, a social work PhD student from Winnipeg.
I'm Harleen, and I'm a medical student and anthropologist from Indiana.
And I'm Harpreet. I'm a clinical researcher and epidemiologist from Toronto. Thanks for joining us, and let's start the conversation.
So hi, everyone. We hope you're doing really well. So we're really happy to welcome you to USRA, the Punjabi Alcohol Resources newest initiative, something we're calling the Saath project. So USRA actually started off as a starting point for Punjabi families who struggle with alcohol use and are seeking help for themselves and or for a loved one. So with this podcast, meaning together in Punjabi, Saath, we really hope to use this podcast to foster unity and support within South Asian communities, not just Punjabi communities. And we really have the ultimate goal of breaking down stigma about addiction-related topics. And we really want to bring awareness through conversation to help each other individually and as a community as a whole. So my name is Harpreet. So I'm actually based in Toronto. I did my master's at the University of Toronto in epidemiology. And during my master's, I spent a lot of time doing alcohol research from a health surveillance lens, which has naturally led me to this space. And then I will let my other co-host introduce herself.
Hi, I'm Ravia. I did not prepare an introduction for myself today. Maybe we'll add this later. But I live in Edmonton or Amiskwaci, Wisconsin, and I also have been working with Astra for a few years. I did undergrad research on addiction in Punjabi communities in Edmonton, and I'm really excited to welcome Dr. Bavenjit Kaur Cheema, who has been a huge part of Astra. She's a co-founder and a longtime member of Astra. She's supported the initiative in many ways, but she's also a primary care physician specializing in addictions medicine in British Columbia, Canada. Bavenjit works in rapid access clinics at and the Roshni clinic in Surrey. She provides care for adults of South Asian descent who are experiencing health-related challenges associated with alcohol and drug use. So we can get started, Harpreet. I'll hand it over to you.
Yeah, for sure. So welcome, Bavenjit. Thanks so much for being here.
Thank you for having me, guys.
Yeah, of course. So I think with your work, we wanted to just start off with the basics. So in your opinion, it doesn't have to be medical as well too. It can just be what do you think addiction is?
So I just want to say, first of all, thank you for having me on the podcast. This is a really exciting initiative, and I'm so excited to see how it goes. So yeah, I'm excited to be here today and talk about addiction from like a physician doctor lens and like how that fits into Punjabi community and see what we can get to. So I think the question we're starting off with is like the most important question, which is like, what is addiction? Like, how do we know when somebody needs help? And this has to be like the hardest part of our community is seeing and admitting and knowing that someone may need help, and usually like for that individual to know that. So I was, as we were kind of thinking about this podcast, thinking about what to share. So it's interesting because like, we'll know a lot of people in our lives who use substances, right? So a lot of people may drink. A lot of people actually may even recreationally use other substances like stimulants or whatever, opiate. Like it could be anything. But what does it mean when somebody actually has an addiction and when it's coming to the point of we need help? So from medical terms, addiction nowadays we don't actually use the word addiction. We use like a use disorder. So somebody can have an alcohol use disorder or an opioid use disorder or a stimulant use disorder. I think that kind of got changed largely also because of like the connotation of addiction and like how people view that. So very specifically, we have like a diagnostic criteria that we look at, which is like 11 different things that people are doing, and that makes us know that they have a use disorder. But like in a summary version of that, there's kind of like four categories. So the first one is impaired control, meaning that you may be trying to cut down on how much you use a substance and finding it to be difficult, or you may intend to use a certain amount of, like, for example, drink a certain amount, but you always seem to drink more than that, what you were expecting. So those types of symptoms fall into like having impaired control over your substance that you're using. And then the second one is physical dependence. So if you start to notice that, for example, you have like physical withdrawal when you're not using that substance or don't obtain that substance. And similarly, if you start to realize that you need to drink more or use more to get the same feeling of elation or whatever it may be with that substance. So that's the second category. And then third is this one's really big because most times in addictions, we talk about like the negative impact on our life, the social impact. So that means like that substance, for example, you may have friends or family who are kind of telling you like, hey, like you think you need to make some changes with how you're drinking or something like that. Or it may be that you're having negative relationships with your family members or your partner or your children, or you're missing work because you're hungover from drinking, or you can't go to work because you need to drink. So that kind of when you start to see that substance impact your day to day living and how you're interacting with people in the world around you, like that's another part of it, classifying a use disorder. And then like a last piece is risky use. So for example, you're using the substance in manners that you know is risky, like drinking and driving is an example of that. And you repeatedly do it despite maybe having negative consequences in that same way. So it's a lot of talking to kind of say that there are ways for us to actually classify when you have a problem that's kind of considered beyond just a casual or recreational use. And in our community, I mean, we can chat more about this, is where like I think that's sometimes the hardest part to recognize because alcohol, not just in Punjabi communities, but like in society, is just a part of life, and a lot of people drink, and that's kind of generally how I'd look at that.
Thanks so much for that explanation. So, since you work quite a bit with South Asian communities within the capacity of an addictions clinic, are there common substance use disorders that you see within specific populations? Do you think it's more broad? What would those be, and how do they kind of interact or maybe differ from each other?
A great question. So I work in two places for addictions mostly right now. One is in a rapid access addiction clinic. So that's like anybody can walk in, low barrier clinic, and have, if they have any problem with addiction, come talk to us. So like we're getting people from all walks of life who are coming in there. And then I also work at a South Asian or Punjabi based clinic. So all of my patients are Punjabi. I would say that like addiction really affects everyone. Like, I see it in the rapid access clinic of like all walks of people, like people who are working, people who are not working, people who are, street entrenched, people who are like have jobs and houses. And like, there's so many people who are affected by it. And we generally see most often, for example, it's like opioid use disorders or alcohol use disorders. And then like more specifically talking about the Punjabi population. So there we definitely have like a mix of the two. We like most of it's usually people are coming in for alcohol use or opioid use, which in our community can often be theme use. And also like fentanyl, hydromorphone, that type of thing. But we'll very commonly see like people are coming in because of their theme use or because of alcohol use. I would say more rarely are we getting people in Punjabi spaces who are coming in, for example, like stimulant use, like cocaine or crystal meth. And like I do see that in, I would say maybe other populations a little bit more. But I think everybody is affected. But in our community, those are the two that we're commonly getting people referred for or what we need to see them for.
So, can you talk a little bit more about theme? So, I know me personally, I'm also Punjabi, but I've only ever heard of theme in the context of songs. And then Ravi also had a great saying that she shared the other day. I think like theme kanda kam karta, like I think that's what you had said the other day, which I thought was funny, but also it's just like interesting how you hear about it kind of like in these like social contexts, but then you don't realize like this is something that people actually really struggle with. So I was wondering if you could actually talk about more about what theme is, how do people use it, and how do you actually notice signs of theme use within those capacities?
Yeah, okay. I love that question. So even as a doctor, before I started doing this work, I actually didn't realize like how much of an issue it was. I think I really I remember when we started Asra, like we had really focused on alcohol because we were like, we know this is a problem. We see it in our communities. We see people struggling. Like this is the issue. And then I started working and I was like, oh my God, like this issue is so intertwined with not always, but sometimes with theme use. Like people will come in with like concurrent, I'm drinking and I use theme. And it's very interesting as a doctor because I just went through this whole criteria of how we diagnose a use disorder. But in our communities, like we usually are very functioning people who use Veeam. Like you're saying, like Veeam vartada kam karda, right? Like it's like they use it, they
Mm.
go to work, they live their life. Like it's not as like that social impact we don't see. And so I've had like, I don't even know the answer to this yet. And I've talked to some colleagues about it, about how we as providers to our community, do we label somebody as a use disorder, and do we actually fit the same parameters that are out there? Because oftentimes people are not necessarily filling all of those parameters, but we're getting people coming to us a lot because I think two things right now. One is like they're hearing about the toxic drug supply, so they realize that either maybe they know somebody who used Veeam and it was mixed with, for example, I know somebody like had a patient mixed with fentanyl or hydromorphone, and they're hearing that the Veeam Jadiatia, like it's not right. And like whereas like back in India they might trust it a bit more, they're not trusting it. So people are coming in because they're scared of that, which is a very
Right.
valid concern in BC where I work. And then the second thing is usually like it's a mixture of financially, are people still do well? Like they're still using like 1 to 2 grand a month on theme, but still doing okay, but realizing like, oh, I don't need to be doing that. In combination with, they start to realize that their body's building quite a tolerance. So they'll be like, oh, I'm realizing I'm having to use more and more. I don't think that's good. I heard some friends got help. So people are coming in for, I feel like those reasons is why I see them come with theme use. And then oftentimes too, you'll have patients who they're using theme, they're also drinking alcohol, but then again, is the alcohol, like they don't know if the alcohol is a problem, it's kind of on the side, but they want help with
Mm.
their theme. So there's a lot of like teasing out of how are these things affecting your life? And let's talk about that.
Hmm.
Hmm. So to clarify, so Theme, it's an opioid then.
Yes, like dode, so like from the flower,
Okay.
and essentially that's where it starts from. But there's different forms of that. Like people will take like just like powder sometimes from the dode plant, but then eventually it can get processed into what's called theme.
Yeah, it's from poppy seeds. So it's like poppy seed tea is what like dode is
Mm.
normally turned into. Like you put it in cha, and then theme is mixed in with cha. I think that's a really good point that you brought up, Bavenjit, about figuring out what is, I don't know if this is the right term, but like problematic use. Like, is this use actually affecting someone to an extent that it's like, do they want help? Is this harmful?
Mhm.
What do you think as a care provider, like, is a good guideline for someone who maybe knows someone that is a FEME user? What do you think is like a good parameter for that person to like be concerned or not concerned about FEME use in like maybe about themselves or someone they know?
Hmm. That's a great question. I think this goes back to where even as a provider, sometimes I struggle with that diagnosis in our community because people do so well even though they're using theme. But I definitely would say like that dependence and tolerance piece is very big. Like if you can't live your life without a substance, then this is probably becoming problematic in your life or will become problematic in your life at some point because how could you live a life if you need something to be functional in your life? So I would say like that's kind of one of those parameters. Like if you feel like you can't live without that thing, then you probably should start talking to somebody about it. The second layer as like a physician is that toxic drug supply is a real concern in Canada, especially in BC, where like,
Absolutely. I think that's really fair because being in Alberta, I think most of our drug supply comes from BC. I don't know what it's
mhm.
like on the East Coast, but or on the eastern part of Canada, but it's like that's where most of our supply comes from here. So I think that's a really fair concern and is applicable to many other communities.
I was wondering if you could talk a little bit about kind of the dangers of co-using alcohol and an opioid, specifically Theme, if that's kind of the drug that's commonly used within South Asian communities.
Yeah, I think that's a good question, like a good thing to bring up because you'll definitely have like there's some patients who are coming in and they just like only drink alcohol. They've never done any other drugs before, and they'll say that like like I just drink alcohol. Like I've never done anything else. And you have that patient population, and then you have that patient population where I feel like most time these patients come in for their theme use, and then also like and I drink alcohol. Like they kind of recognize the alcohol as a second part almost to what they're using, but co-congestion of substances, like so one from like a medical perspective is that we always are worrying about like overdose, right? And death. Like that's what we don't want the outcome to be for a patient. Like that's the worst case scenario. And definitely when you're using things like alcohol that are like a depressant, so make you like sedated and out, like you can black out, you cannot know what you're doing. And if you're using something on top that also could put you into like respiratory distress, not be able to breathe and sleep. So like always when you combine the substances, there's a greater risk of something happening to your health. And I think that is really important for people to know and realize about what they're using. Interestingly enough, we'll also see patients who will be like, I used to drink a lot of alcohol and then I wanted to stop drinking alcohol. So I started using Theme and I haven't drank alcohol in years and I use Theme now. And that kind of goes back to this like, why do you use substances? So it's not even about what you're using, it's that you need to use something to feel okay. And now, what is that about? Which is the hardest part about addiction work is that piece.
My other questions, when I was asking about what are kind of differences in use between populations, I always am a bit timid about that question because I'm concerned about associating specific substance use with different populations in kind of fear that that might create stigma, which again kind of like negatively feeds back into recovery and getting help. So I don't know if you have any thoughts about that.
Yeah, I mean, I think like in some ways, I feel like we do need to name it because the longer we're not naming it, the longer we're pretending it doesn't exist. You know what I mean? Like in some ways, like we need to know that our community, like this might be a stereotype, but like even from what I see, it's like our patients are using Theme. Like that is what's there. And if we don't name that for people, maybe they won't ever realize that they need help with it. So yeah, I wonder about that stigma piece. I think the stigma, if we look at it from like an alcohol perspective, especially, I can see how like, oh, Punjabis drink, Punjabis have problems with drinking. Like that is like a narrative about our people that has some footing, but then not footing everywhere. So I don't know. I wonder about how much naming it and associating certain use to populations is either helpful or negative. I think like within a community, it might be helpful to name it for ourselves, but then like externally, it's not helpful when people are making that stereotype about your people, right? So yeah, I'm
Mhm.
not sure.
Yeah, no, for sure. I think definitely the whole naming aspect probably helps out with the whys.
Yeah. And I think that's a really good point where you're like trying to balance protecting your community, but also trying to address issues in your community.
Mm.
Um, but yeah, my first question is like what you were saying is like understanding that why of someone if someone is using and why are they using. How do you how do you usually find out about that and how does that conversation often go for you?
Yeah. So this is something I feel like the more I've done this work, I'm like, when you first kind of come to training and you've learned like the medications and you've learned the criteria for like if they're gonna have a seizure and like you're worried about all these things. But at the end of the day, when someone comes and talks to you about substance use, of course, like as a physician, we're looking at all of those things. But I will always ask, and why do you use a substance? Like, ਤੁਹਾਨੂੰ ਕਿਉਂ ਲੱਗਦਾ ਤੁਸੀਂ ਸ਼ਰਾਬ ਪੀਂਦੇ ਆ, right? Like, ਕੀ ਫਾਇਦਾ ਮਿਲਦਾ ਤੁਹਾਨੂੰ ਇਹ? Oh, like, and it's really funny because patients always kind of be like, oh, okay. Like, I haven't thought about this. Like, I came to the doctor to get medicine, or I came to the doctor to, like, you know what I mean? Like, physically get some help. But, like, this question is a lot deeper than that. And so you will have patients sometimes, like, pause and be like, interesting question. How do I answer this? But I think that is, like, the starting place. And so I will always say, like, I can help you with medications and I can help you with understanding your risk. But, like, understanding your why is how you'll actually stop drinking alcohol or how you'll actually start using whatever you're using. Like, if you don't understand why you use this substance, these treatments are only going to go so far. Not to say they're not going to be helpful, like they will be, but
Mhm.
for a true resolution, we need to look into that. And with our community, you'll have like mixed things. There's some people like I'll be surprised. Like there's some men who are very reflective and able to like stop and think and kind of ask those questions to themselves. But a lot of men, I'm saying men because we see a lot of men, but it does not mean that we don't see women. We also see women where they just will be like, "Oh, we don't know. Like, I just think ਸਾਨੂੰ ਆਪ ਨੂੰ ਪਤਾ ਨਹੀਂ ਲੱਗਦਾ ਅਸੀਂ ਕਿਉਂ ਪੀਂਦੇ ਆ." Like, I'm asking myself the same question. Like, why do I keep doing this? What's triggering this? And so it is the most important question of addiction and like the hardest question of addiction to answer. But without asking that question, I find like you'll probably be in somewhat of a loop eventually until you get to the bottom of that. Yeah.
Hmm. And what have you found as a physician that's been like the best way to, I guess not like find an answer, but like beyond asking that question, how do you maybe push them to find an answer for themselves in a way that's like reflective and you have
Yeah.
positive responses?
I was thinking about that and I was like, the thing with being a doctor and a physician role is like you end up being a bit limited, right? So I do feel that sometimes where like my expertise don't lie in like counseling and figuring out necessarily how to dig deeper with patients. We do have like some skills like motivational interviewing and that sort of thing, which are like things like asking them to like name excuse me, their pros and cons, like what fava do you get when you drink, and I sometimes ask them that, like, what do you feel like positively giving you? And then I'll ask that flip side question, like, and what do you think are the cons when you drink? Like, what are the
Hmm.
negative things that happen? Like sometimes I try and reflect on that with patients kind of in brief of like, yeah, you know, what is this list? And then about for sure and
Hmm.
to kind of reason in their heads. And I think like sometimes with patients you'll see that eventually a pattern repeats enough times where they start to realize like, oh, I really need to figure this out in order for this pattern to change. I know we had kind of chatted about what to do when things are not going right. Like when somebody's
Hmm.
trying to get help and they're still entering the same cycle, and that happens. And I think as like addictions
Hmm.
providers, as family members, as people around these people who are getting help, like there's going to be this cycle, but I always hope what happens for some of my patients I see, they finally get to like that third cycle and they're like, okay, like this is not working. Let us like dig deeper. So eventually people get there, but it might not be on that first try.
Hmm.
As a provider, like my biggest thing is like I do lean on counseling a lot because I'm like these are the people who have the expertise to dig with you on the why, and it is important to do that. If you feel like you
Hmm.
can't dig on your own, then we need somebody to help you with that.
Hmm.
Sometimes they eventually realize that they need to do that.
And do you find there's like different reasons people will seek help for one substance and not the other? Or, and then I'd like, I guess like an overarching question is, just from your experience, do you think there are any large, like blaring common reasons, like common whys that you've seen
Mm,
in our community?
yeah. So for the first part of that question, like when people reach out for help, I guess like the two main substances we're kind of talking about here is like theme and alcohol, which was what we're kind of seeing in our community. The way we treat opioid use is very much so like with a medicine that makes you feel not sick, and it's very like in some way simple, and also the stigma maybe around the two different things are a little bit different. Like being an alcoholic, I think is almost looked more down upon than like being a theme user. Like a theme user feels like, oh, kind of more common than if you've gotten to the point where alcohol is like destroying your life. So I don't know if that
Mhm.
makes kind of a difference in why patients come for certain things. I would say the blaring why seems to be like not able to regulate emotions in the way that like alcohol is a way to calm down. Like the alcohol is a way to de-stress. The alcohol is a way to fall asleep. The alcohol is a way to like if you're mad, you know what I mean, address how you're feeling. Like there's so much inability to cope in healthy ways, and we talk a lot about that in terms of like what else do you enjoy? Like what else brings you light, And so when the next time you're stressed or the next time something complicated comes up, like what is the list there, And I think this question, like our communities are, we've worked hard, we've made money, we've taken care of our families, but we haven't thought about how to relax on our own. And we've just known alcohol as that because it's almost intuitive as that, like in so many spaces. So I do think, again, that ends up being commonly the why. And obviously there's like way more like, generational trauma, people with the way they were raised, they moved, all these things. But I think at like a simple level, it usually comes down to not knowing how to be chill without having your alcohol.
So when you have that why as a physician, that's between you and your patient. But when the patient is kind of getting to treatment, obviously with Roshni, patients are coming there on their own accord. But kind of like the background of like substance use, especially within Punjabi communities, and I have experience of this as well too, is that the family and the community you have around you is very heavily involved. So whoever is immediately around you. And I know personally when I've been kind of like talking to people close to me and trying to engage them in that why, hey, like, do you think there's a problem? Why do you think this is? Do you think maybe you need to get some help? I find that there's always kind of that halt there where they're kind of like, oh, like, it's no big deal. There's no why. It's just something we do.
Mm.
So I was just curious to know, like, do you how can not the user themselves, but people around the user who want to help them get help, how can they leverage that why to kind of get them to a point where they want to come in for
Mm.
treatment?
Yeah, that is a hard one. Because, part of my job also is like we have like, the wife or the kid or somebody coming with their person, and you sit there and have a conversation, but you ultimately know that the change is going to come from the patient, regardless of I guess in a way my thing for the other person is to help give them understanding of what's going on and how we're helping this person, but knowing that and explaining to them that no matter what we do, this change will come from the patient. And that's a really hard place to be when you're seeing your loved one struggle. And kind of your question is like, even how do you even get them there and to what they want to change in their life or not? And without that realization, it becomes like really hard to have meaningful change because maybe they might come for family and they might come because they're people are telling them things are not going well, but how well do they sustain or do the things that need to be done for something to change if they don't believe it themselves. Um, so I don't know. Like I wish I had better answers for that part for our community, but I don't know what the answers to that part were, to be honest. Like
No, no,
I think
no.
yeah, I was gonna say to like some degree I do think like for example when I learned about well what classifies addiction and what's the definition and what's the signs and symptoms like it's nice to know them because then you can maybe bring those up with people like hey doctors say if this is happening, maybe you have an addiction. Doctors say that if your body is physically withdrawing from this substance, that maybe there's a problem. Like, so there's like, it's like a way to bring up knowledge to that patient to give them information like, hey, this might mean that something's going on. So I do think, yeah, I guess like for family and friends, like understanding addiction and what it looks like and, the examples you can give to somebody may be helpful. Um,
Mhm.
yeah, I did. I was also thinking of something earlier where I was feeling like, I really empathize with my patients because I sit at a desk and I hear their stories and I know I'm hearing like such a small portion of what they're going through. And I like cannot imagine how much effort it takes to change their internal thoughts to make their change with their substance. Like, and I think about like our own selves, like you don't need to be using a substance to understand how hard it is to change. Like think about like maybe all of us have insecurities or, get triggered and yell at somebody when we don't want to be. And no matter how many times you told ourselves, like next time I'm gonna like breathe and you know what I mean, turn my thoughts a different way, we still end up repeating our same pattern because it's so hard to change. And that's just like emotional regulation. But these people
Mhm.
have already developed a, a dependence on a substance helping them with that, and they're trying to change that,
Mhm.
and they're trying not to drink. And so like I sometimes just really feel like this is like the easiest part is me talking to you and giving you advice, and I know that the hardest part is on you. And so sometimes even for family and friends, it's like to remind ourselves, like, what can we change in like let's try and change something in our life and see how hard it is before we and not saying that I know substances can really destroy families and like in so many ways, but just a way to kind of have some empathy for that person as they go through that journey because it's hard and
Mm.
it's frustrating and it's frustrating for everybody involved. But yeah, so those are some things I try
Mhm.
and think about sometimes.
No, I'm really happy you brought that up in terms of how hard it is to change behaviors because I think oftentimes when we talk about substance use, there is kind of that common narrative of, oh, it's a choice, you can stop if you want to. But then I think people kind of forget that whole neurobiological component where, things are actually happening internally that make it very difficult to change.
Yeah, for sure. I think like daru, dawai, when you say alcohol in Punjabi, it translates to medicine. So there is
Yeah.
that like using it as a as a medicine to your emotional dysregulation, maybe. Why does treatment matter, and what value do you think that brings?
Yeah, a good question. And what is treatment and how is treatment given and so many things around that. Um, I would say the reason, maybe even more so than like treatment, the reason for going for help matters is because it names the problem, it makes it real, it makes it something that needs to be addressed. Like when you go talk to somebody about this, you start to realize that I think I need some help, right? So I think that's what the benefit of seeking help ends up being. Yeah, just making that first step of having a conversation is commonly the hardest part. And if you can start with that, you're already on a stepping stone to somewhere. And I always congratulate patients for just even coming in to talking, because I say this is your effort. This isn't me, like you coming in showing up, that's on you. And of course we're gonna help you, but this is the first thing. Without this, nothing else could happen.
Absolutely. I really appreciate that answer.
So I was hoping that you could kind of talk about the different treatments that are available. So specifically because substance use is treated biomedically, so kind of biomedical models for treatment versus community.
Yeah, for sure. So in general, obviously I'm on here as a doctor, but like none of this is actual medical advice. Like please go talk to your personal doctors, professionals for your situation, because it is not the same for everybody. So for example, for alcohol use, as a doctor, we think about like two things. So one is acute withdrawal. So when somebody wants to stop drinking, what will happen to their body if they just randomly stop drinking their alcohol? And then second is like relapse prevention. How do we help you if you stop drinking to like reduce your cravings and not want to drink as much? So the first one being like, we talk about it as like, and not everybody is not safe to stop drinking alcohol right away, especially if you have history of seizures or like delirium, which is like confusion or hallucinations when you don't drink. Like there's many things that can happen. Something people don't know in our community is that alcohol is one of the most dangerous substances to withdraw from. So like it can kill you, whereas other substances actually don't have that same risk, which is really funny because we accept alcohol so much in our community, our society, but it has like so much, it can have detrimental side effects. So yeah, generally speaking, like what I would say if somebody wants to get help is like go see a doctor. We will talk about some resources, but that could be your family doctor. Family doctors have basic understanding and knowledge of alcohol use. Sometimes they're not the most comfortable discussing it, and that's something we should know, because sometimes I feel like you get disappointed. Like you go to a doctor and think, hey, they didn't really help me, but not every doctor has expertise in that area. But you definitely can talk to your family doctor. They should be able to connect you with resources. Like I know in BC, like we have places where we can look up resources, or it's part of our GP's job to kind of know of certain things. So they can direct you to, for example, the rapid access clinic, give you that information. Like, why don't you go speak to these people at this clinic? If you don't have a GP, Google, see if there's clinics around you that have addiction work. Like oftentimes for addictions, you can self-refer and come in. So that's kind of the starting piece. Once you like come and see a doctor, usually what we're going to do is like an assessment of your risk of stopping to drink. And that may mean, for example, like I was saying, if you have seizures or something, it may mean that you need to go into an inpatient detox, for example, which we can help facilitate for you. Or it may mean you can try it at home with certain medications. And so that's where we come in. Like there are medications when you're first stopping to drink because you feel quite crumpy, like you're sweating, you're nauseous, you're vomiting, you're tremoring. It does not feel good. And so there is a medication, for example, like gabapentin is an option, which helps you with those emotions. The other one is benzodiazepines, like diazepam. These are medications that help you in that acute period not to feel so crappy. And then after that period is over, that's usually like a 1 to 7 day period where we're imagining that you're feeling the worst in terms of physical withdrawal symptoms. Then we move on to talking about, this is like the why, right? And then we talk about medications that help with craving. So it's good to know there's two common medications called naltrexone and camprosate that are there for us. They work on the brain to help like reduce the voice in your head that's like, I want to drink, I want to drink, I want to drink, and trying to like turn that down. And, as a doctor, I will say, and whoever is listening to this podcast, like some of these medications work really well. Like I've had patients who are like, I have like a drink in front of me and I don't feel like drinking it on this medication, which is really great. And these medications don't make you feel sick. Like I know there's like preconceptions of medications that like, oh, if you drink alcohol, you're going to vomit and not feel good. And all of those that we don't use those anymore really. So they're not medications that make you feel sick or bad or anything in that way, but they help reduce that thought. So that's like generally speaking, information on some medications. Talk to your doctors about what would make sense for you. But I always frame this conversation, especially for like the latter medications that help with craving, in the sense that this is a tool. So this medication isn't going to solve everything. It's not the magic tablet. It's not going to take away your alcohol use disorder, but it's a tool, and it's a way like physically to help your body not feel crappy. And then there's the counseling, there's the other pieces that we need to do. And our goal is that all of these things will help you. I always talk about that with patients. I'm like, these are tools, and you need to see them as tools to help you rather than something that will fix you, or even something you're dependent on, or something that now you're taking instead of alcohol. Like, this is not the same thing. This is something that's helping you change your brain pattern so that when I take this medication away, you have enough tools that you don't feel like drinking again. So generally speaking, yes, there are medications that can help you, and us doctors can help explain all of them to you and try and figure that out.
Yeah, no, for sure. Because I know also within other therapies and practices, like I've learned that a lot of times it's that medication that acts as that stepping stone and creates that kind of receptiveness to seeking that counseling that kind of helps you understand that why.
Yeah, we can definitely try sharing the resources that we've compiled on the OSRA website, and we'll pop them into the description of this podcast. And I like what you brought up, I really appreciate about what you're speaking about is like this possibility of making the care plan and the treatment options more like better, because you're like, I don't know if this is the best thing. Maybe it could be better. And I think that addresses a lot of the frustrations that people are facing with like reaching or like getting to addiction care or even getting healthcare. So that's like a really large question we won't be answering today, but it is an important question to weave into when we're talking about like why don't people get help. There's so much going on, and based on that, like, so what you said was like there's no one magic solution. What is your ideal care plan that you would say?
I think that ideal care plans for our community involve family and like involve more community. Like I think like sometimes like the way addictions is treated right now for help in like the medicine we follow is very like individual. And I have reiterated in this podcast that I do think part of addiction help is very individual. Like you need to have that individual on board. But a lot of our help, right now in the Western kind of sense is usually that individual goes through certain things to get help and reach a goal. But I think for our people, our community, like our sense of family is so strong, and we like to support and be there. And I don't know what that would look like, but having that type of sense in the supports people get, I think that is important for us. We like try and evolve and provide the best care that we can. Um, but yeah, I think we're at like a good start here, but I know that, and again, like I've put a caveat to like our whole conversation today in the sense that like I do a lot of work in an outpatient setting, meaning I'm doing work where people are coming to me asking for help. Like that's the only people who present to Roshni are people who have actively booked an appointment and actively want to come and talk about their issues, versus, for example, people who work in like the hospital, where you'll get a lot of patients who are presenting because they have liver cirrhosis, because they've had like physical challenges that brought them to the hospital. And it doesn't mean that person thinks they have a problem. It doesn't mean that person wants to get help. And I think this is probably where maybe families get the most frustrated. Like whoever went to the hospital and they didn't do anything. And the problem is because they can only do so much unless that person wants to get help. So I wonder how we'll continue to change it. I think at least having somewhere to go after you're in the hospital, and if you want help, like that's one huge step. But yeah, I think we'll continue to answer this question as we like grow as a community in addictions as well.
So I know we talked about how kind of the process of seeking treatment, getting to that point, how it kind of affects the patient, because that's that's the service user. But I think also because of kind of how complicated addiction is, it's so multidimensional, and you as a physician, you have to deal with so many different moving components and not just the medical treatment, what's informing the medical treatment in terms of the social history. So is there anything that kind of impacts you as a clinician when you are navigating these different cases? So you as a physician, your job is to treat it medically. But then also, given the nature of addiction, people can relapse. And then kind of you have that effort where you help the patient get better, but then the patient relapses. How does that impact you as a clinician where you have these people that you see maybe time and time again where you thought that their addiction was resolved, but it actually turned out they relapsed? And then also kind of dealing with that cultural, social component as well, too, because you yourself identify as Punjabi, you're dealing with Punjabi patients. How do those kind of like different things impact you as a clinician?
When I first started, I felt a lot of sense of responsibility in the sense that, like, if a patient didn't do well, or if I was worried about the plan I made, I feel like, oh, maybe if I had done this, like maybe if I had given them this medication instead, or done it I maybe some distance in some sense to continue to do this work in the way that I'm not responsible for what happens with a patient. Like, I'm doing my best to give the best information and help them. And ultimately it is that person's, like, I'm a part of their addiction journey, but I'm not their journey. And so kind of like, yeah, kind of giving it some distance. It's easier. I don't know, as a provider, it's easier to do that because I will say that, like, obviously in my families and stuff, people struggle with addiction too. And then I know, as like a person who's affected by that, you feel like that impact is way different than, for example, as a provider who is seeing that happen. But in some sense, I guess as a provider, you can kind of have a bit of that level head, like, outside of the emotion of just naming the facts. And I think, like, for example, I kind of alluded to patients of mine who have had like repeat relapses, where I kind of discussed that with them, like, what are we going to change? Like, this is something on this path is not working, right? So I always kind of talk about that as like information and history for us to have in our mind. And I always say, like,
Mm.
you need to store this in your mind, because the next time your mind tells you this is not going to happen, you need to look at the objective past and realize, well, this has happened 3 times. So why will this time be different? And try and use that as a tool. So it's frustrating. I mean, in the sense that you just would love for patients to get better and fix
Mhm.
everything. But I think the whole nature of this conversation has been that there's so much to fix. Like, we can do so much, but then there could still be so much that's there that needs to be worked through. And I think that's why we do see use disorders as like a lifelong condition. Like, you don't just phase out of a use disorder. You've had one, and you're constantly kind of working on that, and you can definitely get better and have that in remission. But you always have it in the back of your mind a little bit that this is something that has struggled with in the past and could come up again. It's not this linear pathway,
Mhm.
like, yeah, it's not the same as
Yeah.
uh, some other medical issues, like you're sick and you're not sick. Like, it just doesn't really necessarily
Yeah.
always work that way.
That's a really good point, and I think that's not commonly understood as it being a lifelong condition.
Mhm.
Um, and seeing it as a lifelong condition, I wanted to follow up on that as like, what does the continuum of care, like, for a lifelong condition look like
Mhm.
from like recognition to the rest of your life?
Yeah, there's so many ways to help with addiction, and not everyone needs the same way. And meaning, for example, like, you can go to outpatient providers, meaning like to a clinic where you see a doctor, you see a counselor, you kind of but you're still at home with your family doing your thing, but you're getting help. And like, that might be what somebody needs. And I think in our community, oftentimes people are really hesitant to leave their day to day life. And so this might be the option, because I think traditionally people think they need to go to rehab, they need to go to treatment center, they need to go away, which might be an option, right? But that's a different modality of care in which, like, you can go to treatment centers where you're there for extended periods of time and you change of environment and you have classes, and these things might help. But just so that we all know that, there are outpatient supports. You don't always need to go into like a inpatient facility, but also there are treatment centers where you might need to go in there, and where is the patient at and what do they need? And then the other missing piece in here, for example, something like detox, which I had mentioned earlier. Detox is meaning that, and I think our community doesn't always know what this means, but detox just means that you go into a facility where there are nurses and doctors who monitor you from a medical standpoint to make sure that you're safe. So if this person wants to stop drinking and we are worried, it could either be that we're worried about their seizure history, or maybe they've tried multiple times at home and they just can't stop drinking and we want to help support them. So, but that's like a short-term thing. That's 5 to 7 days. They're there. We give them medications. We make sure they're safe. We make sure they don't have any withdrawal symptoms, and then we need a plan, right? So after those 7 days, if you don't have a plan, that person is coming home. And if it's coming home to the same environment and the same triggers, how is that going to be? Or if there's a plan in place, that could mean going straight to a treatment center. That could mean going home with counseling and other support. So I do get that common misconception, or sometimes people in our community will be like, just send him somewhere for 5 to 7 days. And I have to explain that I can do that, but I can sometimes do that, but what will that change? That's just a small little break, and that doesn't mean it's all the treatment this person needs. So just as a community, so that we're aware, like, yeah, there's outpatient clinics, there's detox, there's treatment centers, and then when we look at like a lifelong perspective, I think that's really where that one's kind of like hard in some senses, when people start to feel like they're better, like they're like, oh, I haven't used in 3 months or whatever, and then they start to like fall off from their check-ins and their doctors. And I think it's just more important that you continue to check in and realize that like, those are still important to keep yourself on track. And I would say that's kind of like how like, over a long period of time you'd want to engage.
Thank you so much for clarifying and like putting into perspective what it means to do a detox, and like that again, I don't know if that understanding is there.
So I know we talked about a lot in terms of what is addiction, kind of that why component, and then processes of helping help or getting help, and then the different treatment options available. But something I really took away from this conversation is kind of that whole concept of why. So starting from the why, where you had that conversation maybe with yourself or with your family at home of, why is this happening? Maybe there is something that I need to do about it. And then now within the context of a doctor's clinic where you're having that conversation with your physician. And then with, the comments from you and Robbie about this being kind of a lifelong thing sometimes, and that continuum of care, and kind of using that why as that guiding principle throughout your care. I think it's really something I've never heard of before. So thank you so much for sharing that.
Yeah, addiction is complex. There's so much going on, and even taking like the smallest step, I always see as a win. So I think we always need to just remember that part. And take care of ourselves, take care of our loved ones, and mostly, like, I think a lot of people who may listen to this podcast may be family members of people who are struggling, and just know it's not easy on anybody, but we always can just hope that the small steps amount to something. And people who are struggling, and like, know that when you make that small step, like, it's I commend you so much, because I think, like I was trying to reiterate here, and sometimes we can forget, is that this is not easy. It's not easy for you. It's not easy for anybody to change. And so it is a process always.
So I know, Bavenjit, you, in terms of resources, and if people are interested in getting help or getting more information,
we'll link like the phone number you can call on your, usually the person who wants help would call the clinic and book an appointment.
Some other clinics that we have, on the OSRA website as well. There's Severa Medical Clinic in Edmonton that works with South Asian substance use disorders. Yeah.
We have social mental health. So I think that's actually located in Brampton or the Peel region. I know that they do events kind of across the GTA, but I think it's primarily based there. But like Rabia said, a lot of these resources are listed on the OSRA website. So if you're interested, you can definitely check it out there.
Yeah, the OSRA website is BC specific, just so listeners are aware. And it might need to have some things updated, but it has like a good amount of information on it. And yeah, I hope one day we can kind of make something for across Canada too. But that is a place to start.
Absolutely.
Thank you so much.
Yeah.
Yeah.
Great.
Thank you so much. No, this was awesome.
Thanks for joining Saath, the OSRA podcast. If you enjoyed today's episode, please subscribe or follow our social media at osra.now so you never miss an episode. We would love to know what you think about today's episode. Please leave a comment or send us a direct message.
If you have any suggestions for future podcast guests, please fill out the Google form on our website or in the episode description. If you'd like additional information or resources in Punjabi or English, please visit the OSRA website at www.osranow.ca. Thank you!